As Ehab said, today I'm going to talk to you about a couple of unresolved questions regarding tracheostomy. Just some quick disclosures. These are the medical companies that I have some financial relationships with. I'm not going to be speaking about any of their products today at all. With respect to some of the unresolved questions involving tracheostomy, on this slide you see a picture of the cover of Respiratory Care. And the reason I put that there is that for about the last 20 years or so, I've been a peer reviewer for submitted articles to the journal. And for whatever reason, they tend to send me every tracheostomy study that's submitted. And so I've gotten a feel over the years for what issues are being addressed. And the list you see on the left, pretty much every article I've seen in the last 10 or 20 years addresses one or more of these questions, such as, is early versus late tracheostomy the best way to go? How do we wean and decannulate patients with tracheostomy? Is percutaneous tracheostomy superior to open surgical tracheostomy? I think that issue is clearly resolved at this point. Whether to do endoscopy prior to decannulation in all these patients, and when to change trach tubes. And for purposes of this talk, I think the two that are of most interest, certainly to me, and perhaps most unresolved, are the top two. The question of performing a tracheostomy early versus late in a patient who's persistently mechanically ventilated in the intensive care unit. And secondly, how do we proceed with decannulation when time is right for that? So the typical indications for an elective tracheostomy are listed here. Prolonged ventilator dependence is what we're really interested in the topic today, but sometimes to control the airway prior to head and neck surgery, or for patients who have refractory obstructive sleep apnea, chronic aspiration syndromes, patients with advanced neuromuscular disease like ALS, and those who have severe subglottic stenosis or laryngeal paralysis who are refractory to other non-surgical approaches. But mostly what we're talking about when we're deciding whether to tracheostomize a patient early versus late is early versus late in the course of mechanical ventilation in someone that we think is going to be dependent for a while. I think most of us who work in the field are aware of a number of the potential proposed benefits or advantages of tracheostomy as opposed to continued translaryngeal intubation. Those include increased comfort and reduction in sedation need, which we typically do see, improvement in oral care and hygiene once we get the plastic tube out of the throat, a possible reduction in laryngeal and upper airway injury. Trach patients sometimes can speak and swallow more effectively. It may improve our ability to mobilize these patients out of bed or even ambulate. Reduction in dead space ventilation might be important for some of these individuals. It's an easy way to take the patient off and put them back on the ventilator when the airway stays in place. It permits patients leaving the ICU and in fact leaving the hospital with tracheostomy at times. And questionably may facilitate earlier weaning and may possibly lessen the incidence of ventilator-associated pneumonia. This slide just shows a few graphics suggesting some of the advantages of trach versus disadvantages of an endotracheal tube. In the upper left panel, you see the endotracheal tube traversing the cords, and you sometimes will get these ulcerations or other lesions on the cords. Most of my patients in the ICU don't look like this gentleman here, but it does illustrate that some patients, even with a tracheostomy, are able to eat and achieve some mobility. The dead space of the normal airway breathing is depicted here on the left. An oral tracheal tube dead space is that. And then you see the trach volume of dead space ends up being a little bit less. For those marginal patients, maybe that provides some advantage. On the other hand, a tracheostomy is a surgical procedure of sorts, and as such, there are a number of complications that might occur with it. Typically, discussions of the complications of tracheostomy are broken down into several phases. There's the operative phase, during which you might have things like bleeding, or if it's an operative case with use of a bovie, you can actually have airway fires that can be catastrophic, and you see some other issues as well. There's the early postoperative phase, which in my experience is mostly bleeding, but sometimes tubes can get dislodged and hard to get them back in proper position, which is what led me to have the discussion with you yesterday about use of the Weinman tracheostomy exchange kit. And then the later or longer term complications of tracheostomy that we might see even after their discharge from the acute care hospital include such things as subglottic stenosis or a tracheal stenosis, granulation tissue, tracheoesophageal fistula, and what have you. So not a completely benign procedure, although I would say that most of the time things go very well. There was a retrospective sort of study done a number of years ago using something called the Nationwide Inpatient Sample, which is a database looking at discharge coding from acute care hospitals. So they used the ICD-9, the time code for querying that to look and see who had a tracheostomy performed during that admission, and then looked to see if there was a code for one or more of tracheostomy complications. They looked at a database from 38 of the United States and then extrapolated statistically to the entire country and calculated that in that year, 2006, there were about 113,000 tracheostomies done in adults in the United States. There was a 3.2% incidence of tracheostomy complications. That's by coding, mind you, not by chart review. And of those patients who had a tracheostomy, there was a 19.2% mortality. So that's a fairly striking number. And on flipping that around, only 80% of people who have a tracheostomy in the hospital will survive to hospital discharge. However, the mortality did not vary according to whether or not they had a tracheostomy-related complication. The reality is anyone who needs a tracheostomy for prolonged mechanical ventilation has a devastating critical illness and has a high mortality prediction to begin with. They did find some interesting sort of subcategories of patients at higher risk, including those who are over 50 and with cardiac conditions, especially congestive heart failure. So if we're going to talk about early versus late performance of tracheostomy in mechanically ventilated patients, it's important to define what is early and what is late tracheostomy. And that puts us right in the first problem with interpreting the literature in this field. There's a range in the literature of definitions of early as opposed to late tracheostomy. There's a wide variation from in early tracheostomy from 2 to 10 days in studies, and late can be 6 to 29 days. So it's a little bit hard to make direct comparisons between studies and between individuals. However, in general, I would say in the field, most people think of an early tracheostomy as one that's done before 7 or 10 days of mechanical ventilation, and late tracheostomy as being after that. Interestingly, at least in one study, up to a third of patients who are mechanically ventilated for at least 48 hours will end up with a tracheostomy. So it's a very commonly performed procedure. And in fact, I think the incidence is felt to have increased over the years after the development of percutaneous tracheostomy, which makes it much easier to do in the intensive care unit without an operating room visit. So now the next several slides, I'm going to sort of run you through a number of studies relating to the question involved here, early versus late tracheostomy. And we'll start with some individual studies and then look at some systematic or meta-analyses. And I think it'll give you a flavor of some of the competing or conflicting results that you can find in the literature. This first one, and they're roughly in chronologic order, this first one can be considered somewhat of an outlier in terms of its primary findings. This was the Rumbach study in 2004. It was a randomized controlled single center trial in general medical intensive care units. There were 120 subjects. judged likely to need at least 2 weeks of mechanical ventilation. They were randomized to receive a trach within 2 days, which is very early, I think, by anyone's definition, versus late, which would be 14 to 16 days. Their key findings were that there was a significantly lower mortality in the early tracheostomy patients, almost half of those in the late. There was less VAP in the early patients, less time on the ventilator, and a decrease in ICU length of stays. However, there are substantial questions about the validity of this study, including selection of patients. The mortality in the late group is somewhat strikingly high. And even if you look at the survival curves here, one of the things that strikes me is that they are exactly the same until right at 2 weeks when they start to diverge. Well, that happens to be the time when the late patients who were randomized to late trach, when they all got their trach. So I don't know how to explain that, but it makes you wonder exactly what's going on there. As I said, that's sort of an outlier because you'll see fewer trials that suggest a mortality benefit. So in 2010, there's a randomized controlled trial in 12 Italian intensive care units. Taragni is the lead author. Early was defined as 6 to 8 days, late 13 to 15 days. People were randomized to have one or the other. 600 were enrolled and only 419 eventually got a tracheostomy. There was no statistically significant reduction in ventilator-associated pneumonia, and that was their primary outcome from this study. That's what they were studying. But also no significant change in mortality. However, there were more ventilator-free and more ICU-free days in the patients who got early tracheostomy and more successful weaning. And the one graphic I show you there is the incidence of ventilator-associated pneumonia, and you see the curves are actually not statistically different. So it didn't achieve their primary endpoint. The TrackMan trial is one of the more notable trials in this field. This was published in JAMA and came out of the United Kingdom. 72 intensive care units, also randomized prospective trial. Early patients got a trach up to date within 4 days of intubation. Late patients got a trach after 10 days of intubation. There were 909, bigger study. Key findings were no change in mortality, and you see the survival curves there. There was no change in the secondary endpoints in this particular case, including things like ICU and ventilator-free days. Interestingly, as you might expect, 2 out of 3 patients randomized to late tracheostomy never did get a tracheostomy. Some recovered, some got extubated, left the ICU, probably some died. So you definitely will see across these studies, there'll be a higher incidence of trach if you choose to do early versus late tracheostomy, and that really just makes logical sense. There was a retrospective cohort analysis done out of Japan over a 4-year period of time. They looked at all tracheostomy patients who received a trach within 29 days of ICU, of being in the ICU. They found 153, and they did an unusual thing where they broke them down into 4 cohorts depending on the timing of when they got a trach. So this wasn't a predefined group. This is just a retrospective look back. And the quartiles were patients who had a trach 6 days or less, 7 to 10 days, 11 to 14, or greater than 14 days. So 1, 2, 3, 4. Key findings were there was a statistically significant change in mortality in groups 2, 3, and 4 versus the early group. And as you see in the graphic, just focus on the one on the left, the timing of tracheostomy, there was a relationship, there was a correlation with mortality. The later you got your trach, the higher the mortality. Now, again, limited by the retrospective design, you can, off the top of your head, come up with multiple reasons why this does not really is not really hold a lot of water. They may have chosen to do trachs later. There's because of some reason that these patients were at higher risk for mortality. So a lot of potential for bias, but it's just of interest. One of the problems with most of these studies is patients who need a tracheostomy or who might be considered for tracheostomy in the intensive care unit are extremely heterogeneous group. Some have had a massive intracranial hemorrhage or ischemic stroke. Others have had trauma. Others have had have a terrible neuromuscular disease like ALS or a bad case of Guillain-Barré. Others may have septic shock with multi-organ system failure. And comparing all of those is a little bit fraught. So some authors have chosen to look at very specific groups of patients who we know have a high likelihood of requiring prolonged mechanical ventilation. For example, severe stroke requiring intubation and mechanical ventilation. And so the SET.2 trial set out to study that particular group of patients. They had only one endpoint chosen for the study, and that was functional recovery at 6 months after enrollment in the trial. So it's a randomized controlled trial. These are severe stroke patients. They're on the ventilator, expected to stay on the vent. Early was less than or equal to 5 days of tracheostomy. Standard or prolonged or late was considered 10 days or later. It was done in Germany and the United States. There were 366 patients. And again, the endpoint was 6-month functional outcome based on a validated scale. Key finding here was that there was no significant change in the two groups in terms of 6-month functional outcome. And the forest plot that I chose for this just looked at a number of different subgroups. I didn't leave the titles on there, but things like age and gender and size and so forth. And there was really no signal in any subgroup that early tracheostomy affected the 6-month functional outcome in any useful way. So now there also have been a number of systematic studies, mostly meta-analyses, looking at the literature as a whole. Again, these are all going to be somewhat impeded by the fact that the original studies enrolled a heterogeneous population of patients with multiple diseases, and some of those may be good candidates for early versus late tracheostomy, and others may not be, and we may be losing any signal that exists. So Zachmani in 2015 did a meta-analysis of 14 trials. There were over 2,400 patients who were in these trials. Early was generally within 10 days of intubation. Late was after that. There was no change in this study in ICU or ventilator days, no change in mortality in the two groups, no change in VAP. But they did see a decrease in sedation and, of course, an increase in tracheostomy in the early trach group. Osakawa in 2015, also a meta-analysis study of 12 studies. Now, some of these meta-analyses are including the same primary studies, as you might imagine, so a lot of overlap. They did something different. They, a priori, they separated the groups into 3 categories based on the timing of tracheostomy. There was less than 4 versus greater than 10 days, less than or equal to 4 versus greater than or equal to 5 days, or less than 10, less than or equal to 10 or greater than 10. And these were sort of from taking a cue from the primary studies. Their key findings were they did find more ventilator-free days, a decrease in the ICU length of stay in early trachs, a decrease in sedation usage, and a decrease in long-term but not short-term mortality. Again, kind of hard to figure out what that means. The graph here on the bottom just shows you the ventilator-free days, and the summation does show confidence intervals on the side of the line favoring early tracheostomy, but with the limitations we discussed. Now, here's a meta-analysis that does seek to narrow the focus to a particular category of patients with respiratory failure, and that would be patients with acute brain injury. And I believe that was not only traumatic brain injury, but also varieties of stroke. So these were patients with a devastating neurologic injury who were intubated and expected to remain ventilated for a period of time. It was a meta-analysis of 10 trials. Early was defined as less than or equal to 10 days, and late over 10 days. There were 503 subjects overall. Key findings were that there was a reduced, again, long-term but not short-term mortality that was significant, and a decrease in duration of ventilation in the early group, and a decrease in ICU length of stay. Chorath in 2021, another meta-analysis, this time 17 trials, so we're starting to get more and more trials included in the studies. Here, early was less than or equal to 7 days, and late was over 7 days. Now, a total of over 3,000 patients enrolled in all of these trials. Key findings were no change in mortality. There did seem to be a decrease in VAP, and you see that the confidence intervals just barely touched the line of unity. And there was an increase in ICU length of stay, a decrease in ICU length of stay, and an increase in ventilator-free days with early tracheostomy. Here is a Cochrane review, and like some of the Cochrane reviews, is somewhat humorous in that they will they'll review the literature and try to find an answer to the problem, but basically they're analyzing trials of good quality that are prospective randomized controlled trials. So this is a COVID study of early versus late trach. They did find one randomized controlled trial, and 24 non-randomized controlled trial in COVID-19, but really the data just comes from the one randomized controlled trial, right? So the findings there were no change in mortality with early versus late trach, no change in ICU ventilation, ICU or ventilator duration, and no change in ventilator-associated pneumonia in COVID. Finally, Villemure-Poliquin in 2023 did a meta-analysis of 9 trials, 2,400 patients. Less than 10 days is early, greater than 10 days was considered late or prolonged. These were non-neurologically injured patients, so, excluding that group, but taking all the other comers. There was no change in hospital mortality, no change in hospital or ICU length of stay, and no change in duration of ventilation, no change in VAP. And then, wouldn't you know it, in the last 2 months, there's yet another meta-analysis published, and this time in British Medical Journal, open access. Varies a larger number of trials included now, of course, larger number of patients, but very similar findings to all these presented. So in summary, many of these trials individually or meta-analyses have shown some positive findings of interest, typically things like decreased time on the ventilator, decreased ICU length of stay. The mortality benefit in the 1 or 2 studies is very questionable and probably not real. So the question does sort of remain whether early versus late tracheostomy is beneficial. And, as you will hear from me, again, it all depends, and it all depends on the individual patient. I think patient selection is extremely important, and that we can't have one guideline that fits all patients mechanically ventilated. It's of interest that if you just go back in time to 1989 and read these guidelines from the National Association of Medical Directors of Respiratory Care, which were actually developed because there was a change in funding the DRG system at the time, and this code for tracheostomy, mechanical ventilation requiring tracheostomy came out, and hospitals were being paid a lot more if you did a tracheostomy than if you just kept a patient translaryngally intubated. The NAMDARC came up with some guidelines to try to address this issue, including some of the ethical issues facing physicians and caregivers. But within that were some guidelines about when to do tracheostomy. It's interesting to read these. They say for anticipated need of the artificial airway up to 10 days, translaryngeal route is preferred. In other words, don't do a trach early on. If they're expected to need the airway greater than 21 days, consider a trach. When the time is anticipated, with the time anticipated for maintenance of an artificial airway is not clear, you should do a daily assessment. Okay, that seems reasonable. And then the decision to convert to tracheotomy should be made as early as possible in the course of management to minimize the duration of translaryngeal intubation when you know they need it, right? All logical things. But I would say that these guidelines, even though they're 35, 36 years old now, these continue to guide practice. I mean, that's what we see in the community, these types of decisions. There's a more recent guideline from a French expert panel. I've just sort of shown you the highlights of that here. Again, mostly it's somewhat vague and more common sense. The first suggestion was that experts suggest that tracheotomy be proposed in cases of prolonged weaning from mechanical ventilation and acquired and potentially reversible neuromuscular disorder. This is a very low quality of evidence recommendation, like expert opinion only. The second one was also expert opinion only. Experts suggest that the indication for tracheotomy in patients with chronic respiratory failure should be the subject of a multidisciplinary discussion. Okay, that seems good. And then the only grade 1+ recommendation was that tracheostomy in intensive care should not be performed before the 4th day of mechanical ventilation. And I think that one is based on one of the trials you saw where day 4 was the definition of early trach, and they did randomize patients to get that, and it was not beneficial. So really the key then becomes, in terms of deciding when to do tracheostomy, in my mind, is being able to predict the need for long-term mechanical ventilation. I think if I had a crystal ball and I know my patient is going to be on the ventilator 2 months from now, I want to do the trach now, today, because I do believe that tracheostomy has all of those benefits that we discussed previously. Whether it's done late or not, we do reduce sedation. We are able to mobilize patients more. Some of them can talk, some of them can eat. And so we want to give them that opportunity as soon as it appears that they're going to require prolonged mechanical ventilation. There have been some people who've developed some scoring systems to try to predict this, and my understanding is that they're not very useful, and I don't use them. But conditions like a very severe brain injury, stroke, TBI, anoxic injury with a chronic disorder of consciousness might be somebody who you can predict will need that. Patients with certain neuromuscular diseases, I mean, with ALS, once you're intubated, almost all those patients are going to need a trach if that's within their goals of care. Certain patients with polytrauma, someone with a very high cervical cord injury who has eliminated their phrenic function, probably going to need long-term mechanical ventilation, at least until they can get some sort of phrenic or diaphragmatic pacing. If they want to go that route, they need a trach. Some patients with severe chronic lung disease that's irreversible or unresolving ARDS will need a trach. So in summary, tracheostomy is an invasive procedure that has real complications at a fairly high clip, actually. Early is usually within 5, 7, or 10 days of intubation. Later is after that. The research is, I would say, not supportive of universal early tracheostomy in ICU patients. That is, in just everybody on a ventilator that you guess is going to be on the vent for a week or two. Probably not justified for that. But timing should be tailored to each patient's unique situation, including the risks. You know, they have a coagulopathy or some anatomical derangement, specific pathology pattern, whether it's neuromuscular disease or trauma or primary lung disease, organ system dysfunction, or overall, and their overall clinical trajectory. Okay, no, we're good. There's a lot of wires here.
Yeah, something.
No, I think we're good. Oh, we lost that. Okay. Oh, what's that?
You just put from the wall.
No, that is okay.
For a reason. This is okay.
Okay, let's not do too much. Okay, so that's early versus late tracheostomy. How are we doing on time? The second question I chose to address in this talk is the question of how do we wean and decannulate patients from tracheostomy? What's the protocol for that? And again, like the previous topic, this applies to a certain category of patients. This is not the patient who had head and neck surgery, where the head and neck surgeon is going to decide, you know, once they've removed the tumor or whatever, they can take the trach out, and that's straightforward. Just do it. Or patients with severe trauma where we put the trach in, they didn't actually really need it. You don't have to go through a long process. This is mostly the kinds of patients that I'm seeing who are in a chronic phase, either in a rehab unit, long-term acute care, or subacute unit, whose acute phase may have resolved or tamped down, but now they have a trach and are weaned from the ventilator. So saying that, the criteria and the approach varies widely from center to center. There are no specific guidelines, for example, from the AARC about you have to do it A, B, C, and D. Some centers will do a CT of the neck or an endoscopic exam, laryngoscopy, bronchoscopy, in every case before they decannulate. And I do know practitioners in the community in my field, pulmonary and critical care, who will do a bronchoscopy, laryngoscopy in every case. I think that's a bit of overkill, but that is a question, and you will see some literature that recommends doing that. So there's no scientifically proven optimal approach, although many recommended techniques are described, and we'll talk about a few. There is some data that suggesting that a multidisciplinary approach is a better way to go, involving not only the treating physician, but clinicians like speech therapists, physical therapists, and nursing care, of course. In terms of the prerequisites for decannulation, some of them are fairly clear-cut and others not so much. Obviously, mechanical ventilation is no longer required. So the patient needs to be off of the mechanical ventilator, and it needs to be the judgment of those taking care of the patient that they don't need reinstitution of the ventilator in the short term. Absence of significant upper airway obstruction, whether that be laryngeal edema or bilateral vocal cord paralysis, subglottic stenosis, granulation tissue at the side of the trach. All these can sometimes impair breathing when the trach is removed and should be excluded in one way or the other. Most clinicians would like the patient to have a satisfactory cough and a low frequency of need for suctioning prior to removing the airway, because once that's gone, there really is no pragmatic way to clear secretions effectively. That's typically associated with recovery of an acceptable neurologic status, but not always. Preferably minimal secretions. Some places would like and would require a particular level of neurologic function, perhaps a particular threshold for Glasgow Coma Scale, or swallow function. Depicted on the right here is a table from a study of clinicians around the world asking what they felt was the 2 or 3 most important issues to resolve before decannulation could be considered. And you'll see that the ones that scored highest were, and it was a Likert scale, 7-point Likert scale. So the ones that scored highest were level of consciousness, ability to tolerate capping of the trach tube, cough effectiveness, and secretions, presumably decrease in secretions. So I thought it would be of interest for this presentation to look at tracheostomy patients that I have and a couple of my associates have in a snapshot right now in long-term care facilities. And that includes in our town a long-term acute care facility, Kindred Hospital, and 2 or 3 subacute facilities where my associates and I, all of our patients have tracheostomies. Some of them are on the ventilator, but most are trach without the ventilator. And I looked at all those patients and just decided, what is the reason right now why the patient still has a tracheostomy? Not necessarily why they get the trach on day one, but right now, why does that patient have a tracheostomy present? And there were 162 patients that we're taking care of right now with trachs. And of those, most of them have the trach now because of some sort of profound neurologic disorder. So the 2 of the top ones are a chronic disorder of consciousness due to a traumatic brain injury, or a chronic disorder of consciousness. By that I mean vegetative state or minimally conscious state following an ischemic injury. So there were 29 of TBI, 34 ischemic injury who still have a trach. Stroke, intracranial hemorrhage, and airway protection was another big category. And then there was also a big category of patients with neuromuscular disease, multiple sclerosis of an advanced phase, amyotrophic lateral sclerosis, high spinal cord injury, Guillain-Barré that never resolved. So we have a number of those. So that just gives you an idea of what kind of patients we're looking at with trachs. And our approach to weaning and decannulation may be perhaps different than folks who work only in STAC, short-term acute care. Maybe it's a trauma place where most of the patients have had trauma. Those patients have a different prognosis and a different prognosis for decannulation than patients with TBI and a chronic disorder of consciousness or ischemic injury. So we'll just look at 4 techniques of decannulation that have been described in the literature, not necessarily highly well studied, but they're there. One approach involves progressive capping trials. And as an example, not a strict guideline, maybe 12, 24, 48, or 72 hours of capping. What I observed is that sometimes patients need to acclimate to capping, and patients who fail capping in the first 30 minutes on the first day, that doesn't mean that it's all done and you got to do something different. You can try again tomorrow and the next day. If they repeatedly fail, then that's failure. In one study published by Rumbach, 30 minutes of success with capping would predict a successful decannulation. This was an uncontrolled trial. There were 75 patients with trachs. 63 of those passed an initial capping trial for 30 minutes. Bronchoscopy was done by plan in all those subjects just to see what they found. And only those that failed the capping trial had clinically significant findings at endoscopy, which in my mind supports the notion that not everybody needs endoscopy if they pass whatever protocol you use. But this kind of study, it's not controlled. How did they select their patients with trachs? Were they not real sick patients? You can't draw a lot of conclusions from these kind of trials, but it's there. A second approach is a progressive decrease in the size of the trach tube. I would say in San Diego where I work, that used to be something that we did. We don't tend to do that much anymore. And in that case, you downsize the trach serially until you get to the smallest trach, which in an adult is at least the old version of the Shiley number 4 is about as small as it goes. And you allow the stoma to kind of tighten and decrease around the trach. When you do that, it tends to close quicker. And in one observational study, there was an 80% success rate. The flavor you get from some of these is that sometimes whatever you do is going to work as long as the patient has does not have some anatomical problem or a neurologic deficit that makes this unfeasible. A third approach is immediate decannulation after endoscopic inspection of the airway. And so in the Cohen trial described here, there was a brief capping trial followed by decannulation after there was laryngoscopy and bronchoscopy showing that the airway was patent, obviously only for highly selected patients. Again, they probably didn't have patients with ALS. You wouldn't decannulate them. They need a ventilator. Probably didn't have patients who were a very low Glasgow coma score. And then finally, there's one study in the literature of heated, humidified, high-flow oxygen via the trach, and there is an adapter you can do that with, coupled with a low frequency of suction as an approach to weaning and decannulation. And in the Hernandez-Martinez trial published in the New England Journal, they randomized patients to a trial of either stepwise capping up to the point where they got 24 hours of capping versus just high flow, humidified, heated oxygen delivered at the trach site, no capping, but observing how much suctioning. And when suctioning was less than, I think, 2 times in 8 hours, they allowed the patients to be decannulated. So what Hernandez-Martinez showed was that there was 7 days less time to decannulation and less pneumonia or bronchitis in that group, and a similar rate of decannulation overall. So everybody who was going to got decannulated. It's just that the heated, humidified, high flow oxygen seemed to speed that up. And here's the curve showing that. The control group is in green and the heated high flow group in red. And the x-axis there is the percent of patients who got decannulated. The ironic thing for me is that I remember this trial. It was submitted to respiratory care, and it's the only one in the literature. And I can't remember what my decision on it was, but evidently we did decline it. When I review, it's with 2 or 3 other reviewers and then the editor as well. And we must have declined the article. Then it got published in the New England Journal. So, Dr. Fung is gone, but if he wants to submit his N of 2 trial to respiratory care, we'll turn it down and then maybe he'll get the New England Journal. So I think we told them to go back and do more subjects and tune up the trial, and presumably they did, and they did better, I guess, than respiratory care. So there is a question about whether, as I mentioned, whether endoscopic examination, laryngoscopy and tracheostomy, or bronchoscopy or tracheoscopy, should be done prior to decannulation. There's a study out of Brazil by Rodriguez where they had 51 tracheostomy patients who were off the ventilator they thought were potentially ready for decannulation. They had a trach for a mean of 46 days. What they do in their center is once they no longer need the ventilator, they downsize the trach to they downsize the plastic cuff trach to a metal trach without a cuff. They capped the patient for 24 hours, and if they could pass that, they were considered clinically fit, potentially for decannulation. Then they endoscoped everybody. They looked, and of those 40 patients who were considered clinically fit, meaning they passed capping, 8 of them were found to have lesions that contraindicated decannulation. So if you capped only and you considered success with that sufficient to decannulate, apparently in this trial you would have missed 8 patients who they judged as unsuitable for decannulation. But I'm not sure how well I believe that conclusion, because shown on the right are the 8 patients and what their findings were at bronchoscopic evaluation. And 2 of them had what are probably very significant problems, but 6 of them had what's called grade 2 tracheomalacia. I had to look that up, but it's a scoring system coming out of the pediatric literature. And basically you forcibly make the patient forcibly cough. And if they have a reduction in the diameter of 50% of the trachea or more, they considered that insufficient for decannulation. And I can tell you, I see that not uncommonly in my patients, because most of these patients get bronch at some point for some reason. And I decannulate a lot of them and they do just fine. So I don't think that's really a contraindication, but a subject for others to argue about. So what do I do? Again, my patients might be slightly different than ones in some of these studies. What I do is once the patient's off the ventilator and they appear to have some sort of control of their secretions, I will start cuff deflation. And whenever they're tolerating that, I'll change them to a cuffless trach. All right. Then I start using a speaking valve. The only one I'm aware of is the Passy-Muir valve. It's a one-way valve attached to the trach. I'm sure all respiratory therapists are familiar with it. We'll start that, and as soon as the patient can tolerate it, we'll increase it stepwise until they can tolerate it around the clock. If the secretions seem to be manageable, we don't think we're having to suction them every couple of hours or so, then we'll begin capping. We'll, again, kind of rapidly escalate that based on their tolerance to 24 hours a day. And then I kind of make a judgment depending on where the patient is. If my patient is in the STAC or in the long-term acute care where there's a physician visit every day and a high level of scrutiny, we might decannulate after 24 hours of capping. Out in the subacute where I only see the patient maybe once a week, there's not a physician of any kind visiting every day, we'll usually leave them capped for several days to make sure we're sure. At any point along that way, if there's any intolerance of either the speaking valve or the capping, then I'll do laryngoscopy and bronchoscopy and try to find out what's going on. And if there's a remediable lesion, I'll refer them to an interventional pulmonologist for ablation or an ENT if that's the appropriate specialist. There are other issues with decannulation. Not going to get into them in any detail today, but there are patients who get decannulated successfully but have delayed closure. It's a very low incidence. I don't know, maybe between 2 and 5% in my experience, but they're problematic. It's hard to know what to do with them. And I've had conversations with ENT doctors, and every one of them will recommend something different. For patients who fail decannulation, kind of depends on whether that happens early on or late. Early patients who fail early and don't close their tracheostoma right away, you can insert a trach tube back in the hole, or maybe a smaller one, maybe a cuffless one. I have used actually the Weinmann trach exchange kit to put a new trach in because it has the dilators and even the blue rhino. For patients who require mechanical ventilation again later or even early if the tracheostoma is closed, they're just going to have to be orally intubated again. And then elective tracheostomy can be done or revision after that. And then I won't talk about it, but there used to be at least available these tracheal plugs or stoma plug. There was one on the market that used to be called the Olympic button. which was a device that would maintain the patency of the stoma, but there was no portion of the tube in the airway except from some sort of little grippers on the mucosa on the inside. I used to use those successfully as a sort of a way to preserve the stoma and watch the patient for a few days. And if they were failing, it was easy to reinsert a trach because it kept the patency of the stoma. But they're hard to get in my experience nowadays, and I just don't use them much. They also used to fall out. And I think that's the end of my talk. So if there's time, be glad to entertain any questions you have.
Thank you so much, David. Any questions for?
Lethal emergency. And so in those cases, I strongly believe that use of an exchange kit can be very helpful. And again, while we're setting up, I'm just going to tell you about 2 cases within the last 2 weeks on my service. I have a patient who had a fresh trach done at one of our hospitals. I wasn't on service at the time. My 7 days, 1 week after the trach was placed, and that is in generally accepted time when the trach change could be done if you needed to. But this is a patient who's ventilator dependent, developed a refractory cuff leak. My partner and my physician assistant went upstairs to try to change the trach, and there was a problem. Patient had a brief cardiac arrest. Fortunately, they were able eventually to get the trach in, and the patient survived. Now he's on my service at a different facility. But I guarantee you, had they been familiar with and had used this tracheostomy exchange kit, it would have been smooth sailing. Another case that's a patient that's on my service now is a man who had a tracheostomy placed. The surgeon who placed it, the patient's anatomy would have, in this particular case, called for the extra long trach. The Shiley extra long trachs have kind of a flat tip that makes it a little harder to do a percutaneous trach. You can do it, but sometimes it's a little more difficult. Surgeon chose not to do that and use a conventional short trach. That didn't work out. The patient was not being ventilated well, and this is a day after it's put in. I went up with my partner, used the exchange procedure. We put an XLT in, no problem. So this thing can be very helpful. A few years ago, in order to try to educate my colleagues, my partners on the use of this, I made this video with our nurse practitioner at the time. So we'll show that. And then, as he had said, all of you who would like can come up to the table and actually put your hands on and do this yourself. Yeah, can we play it? Is there sound? If not, I'll narrate it. Sound.
Yeah, the sound working. Right? Yeah, I had a problem with the sound earlier of. It is turned. Huh? We need to be narrated. Oh. And when I tried to play my video, so it has songs, it didn't show why. But I thought it's like a problem with my folders, with my file. It could be an can you kind of say it here?
Yes, yes.
Okay, we'll start from the beginning.
Yeah. So sound's not working, so I'll narrate this for you. This is a patient who agreed and consented to allow us to videotape him. And in addition, we covered his face with a towel to protect his confidentiality. This was not a case where we felt like we absolutely needed to use the exchanger. We could have changed this trach probably more routinely, but this was to show you how to do this. This patient is on a trach collar. So the first thing we do is we get the trach that we intend to insert. In this case, it is one of those Shiley Covidian XLT tubes, cuffless in this case. First thing, what I'm showing there is the stylet that we're going to put through the existing trach, and then the series of blue dilators that come in the kit. First thing we're going to do is take our new trach, the one we want to put in, and we're going to fit it with the appropriately sized dilator. So Roshni there, my nurse practitioner, is putting the dilator in. We're extending the tip out past the tip of the tracheostomy tube, and you see that it makes a nice sort of taper from the tip of the dilator up to the tip of the endotracheal tube. You can actually see in this Shiley XLT tube that there's a little bit more of a step up than there are with the typical percutaneous trach tubes, but it will work. So now we're going to deflate the cuff on the existing trach tube, which I can tell is also an XLT tube. We're going to take the stylet that is provided in the kit. We're going to check the length, to make sure that we have the right amount of length in the airway, but not too much so that we're not down in the lung past the carina. Next, we're going to put the stylet, and it's yellow in color. We're going to place that into the tracheostomy tube. We're going to control that, and then we're going to remove the existing tracheostomy tube. This patient's not sedated, so he's coughing and feeling this. So Roshni will remove the tube. She's going to control the stylet at the level of the stoma there so we don't lose it. So we still got control of the airway. Now we're going to fit the dilator and the new trach complex over the stylet. Now the stylet is going to guide the tip, which you see is very narrow. So no matter what the anatomy, almost in every case, you're able to just push right on through. Now the trach is seated in the trachea, and we're going to remove both the stylet and the dilator, and the job is done. Easy peasy. So that's the Weinman tracheostomy exchange kit in use. If time permits, we also have, I think, the Milker cricothyrotomy kit up here, and the mannequin that Cook has kindly provided will allow us to show both of those if you like.
Yeah,
So
so
I think what we'd like to do is invite all those who are interested to come up to the table, and we'll go through use of the kit and allow you to do it yourself if you like.
yeah, I'm
Thanks.
just gonna turn the computer, the screen so you can show. Yeah, so you basically show people like from virtual.
Oh, okay, good.
Yeah, so
That is.
So please, come in and get your hands dirty. That patient's not gonna cough on you or. Are you on the mic?
Okay, yeah.
Oh, just push it. We already have it.
We could also use them.
Right now, right? So there's the line. So that's a good point. I get problem. I think we can start doing that.
Is it just overstretched?
So we'll keep that.
So this is the whole kit here.
Sometimes we move this around.
So loading dilator.
I think that's
Each one's corresponds to the size of tracheostomy tube. Airway exchange catheter, dilator. To rapid adapters.
So can so those are just so you can see. I'm just gonna pull in one. But please, come.
So does somebody want to
This
come
is the
and put
virtual.
your hands up? Somebody who's right there.
Yeah.
You want to do it? Yeah.
Sure.
So,
What side should we
so what are we going to change?
So we have a flex 8.5 and then we have an EVAC flex 7.5.
Yeah, so the first thing we want to do is find which of the dilators will fit this and fit it with that.
What size is that?
7.5.
Yeah, it's just quality.
This is what we need. all glands will be a little bit different. You just, yeah.
So do that ahead of time.
Oh, yes, you want to do that ahead of time and get the one that's pretty much the tightest fit. I usually like to put a little lubricant, either water soluble, or actually I prefer to use the silicone lubricant that I use for bronchoscopy. So that once I have the trach in, I can get the stylet out without cannulating. Yeah, that's good. Actually, a little further is fine as well. The key thing is that you've got a nice angle there, very little step off, so that the resistance as you go through the tissues, or in some cases you have to bump over a cartilage, and this makes it easier to do that. Yeah, you put your stylet in, so now you're in the trachea. Move your existing trach tube. I usually like to do this as a two-person thing, where maybe I'm pulling off the trach and the other person secures the stylet so that we don't accidentally remove it. So you've got the stylet out there. Control that. Push it on in. It's actually easier in real life because the friction here is a little bit much from the rubber. There you go. Bada boom. Yeah. Who's next? It's, part of the reason for doing this, in my mind, is it's good to have that muscle memory, so that having done it once or twice, you know that you can do this.
Sorry, my eyes are really bad.
Yeah, it's okay, because you're gonna, again, you can try several of them, and whichever one fits the best is the one you want to use. Yes. Yes.
All right.
Okay.
You only recommend this for like, let's see, people that are like recently stressed, right? Like not for long term.
Right, where I would use it, yeah, the patient I described, who was just a week out from the trach, and supposedly, the ENT docs say you can change the trach in a week, but if your patient's on a ventilator and they've got other comorbidities, you don't want to have an accident occur and they have no support. So I would use it in patients where I need to change the trach for some reason early, or if very obese patients that I think I might actually have a problem putting the new trach in, might go in a false passage. It's really easy to do it this way.
In that video, were you upsizing or downsizing?
We were just changing from a cup to a cup less. We weren't really upsizing. And like I said, in most patients, you don't need to use a device like this. But when you do, it can make the difference between life and death. It's like using a bougie to intubate or a bronchoscope.
We do trach changes, but we just downsize. But I could see how something like this would be nice.
Yeah, and if you do need to upsize, for example, there are cases where you feel like the existing trach is too small. This might be a time when you could use this. The kit also has this, which is essentially the blue rhino that comes with a percutaneous trach kit. And so sometimes if you're having trouble passing your new trach, even though you have the stylet, you leave your stylet in, and you can use the blue rhino over the stylet to redilate the track. Then you go back to your new trach and test that.
And so how do your RTs participate in this role at your facility?
The hospitals where I've used this, I've only done this, well.
Oh, how about that?
I haven't had RTs use this personally, but I do work at a Kindred hospital. You're familiar with long-term acute care, where there's no physician in the house at night. So one of my partners has trained the respiratory therapist there to do this in the event that a patient overnight decannulates themselves. Well, there's a way you can use it if they're decannulating, but if they need an emergency trach change, let's say for a cuff that's blown, they can do that.
I can see this would be great in patients that are known to have false tracks or something
Absolutely.
like that. You get a lot of nursing homes that come in.
Yeah, I would not recommend using this in every trach change. Like I said, 99% of the time, trach change is very straightforward, and the operator that comes in the trach, no problem. But when you have trouble,
Sorry.
No, I'm not. It's fine.
Patients would die.
Scalpel.
Yeah, as for an emergency cricothyrotomy, yeah, so you guys wanna look at that?
Because if you sent this
The other thing you can.
and it wasn't over that yellow catheter.
And this
You have
is
the
just
potential
one
of
of
hitting that back
many
wall.
types of kits that are available.
It
This
is
happens to be the one that
exactly.
have in
Train
our
drag.
hospitals.
You know, it's not gonna deviate.
Accustomed to using. I've got some colleagues in San Diego who used to be with the Navy and they've used various different things in battlefield situations, but this one works pretty good. The basics of the cricothyrotomy kit are there's a guide wire, there's a needle, actually a couple different types of needles you can use, and a syringe. There's a scalpel, and then this particular kit has a small bore cuffless trach. There's another kit that Cook makes that has a cuff one if you prefer that. For me, when I've had to do emergency cricothyrotomies, it's been an emergency. These patients are either arresting or about to arrest because of upper airway obstruction or possible intubation. And all I want to do is get in there so I can provide oxygen, and you can ventilate to a certain extent with this until somebody can do a trach. They come along and do a tracheostomy, surgeon, ENT, for example. So in this case, what you're doing is you're going through the cricothyroid membrane. You can kind of see on this model where it is. The thyroid and the cricoid cartilage.
You've also got the little trachea right there. Just
Right,
just to
it's
like,
a model.
yeah.
So what you're gonna do is you're gonna palpate the cricothyroid membrane. If I have somebody who's in the process of a difficult intubation, sometimes I'll prep the skin and feel ahead of time, while my partner or somebody else is trying the intubation, I'll make the neck ready for the procedure so we can go quickly and get the kid out. And sometimes you can open it up, and if things go well, we throw it away. And then we find it. So you find your cricothyroid membrane. I like to use a syringe. I suppose you could do it without a syringe. Listen for airflow, but once you're in there, you get air back. You know you're good. You grab the guide wire. Some people will make a skin nick beforehand and keeps that. I don't tend to do that. I'll make the skin nick later. So now, after having the guide wire in place, I would sometimes make a skin nick with it. Well, you don't get to do that because it's this. But once you've done that, then you can use this, which is a dilator. In this case, I don't. Does it look here? Yeah, it does. You put your dilator in there. Very similar to the tracheostomy exchange kit now, where you've got dilator through your new trach, if you will, cricothyrotomy device. And you just pass that over. It's the airway, bring these out. And, this adapter will fit your ambu bag, so you can ventilate the patient. Yes, you're going to have a big air leak, no problem. You're going to get enough air and oxygen in there to save their life until someone can do a more conventional tracheostomy. Or you can just use a dilator kit and upsize to a regular. You can go through the cric, you can spread it open and put a 6 or so a tracheostomy in there with a cuff that buys you some time.
I'm just trying to get it clear. You already did the cric?
Yeah.
Yeah.
So
if you want to do it again, or if somebody wants to do it himself, I just want to make sure that the virtual, the people online can see it. So I'm
somebody want to do a cricothyrotomy here?
Yeah, you can't kill the mannequin.
Yeah, this is we'll just leave the wire like that.
So you're going to move this kind. You can set it
Okay,
down.
so
Okay.
What do I have there? I'll lift this
are you
guy.
right-handed?
Yeah.
Yeah, easier when you're on the right side of the patient. Yeah. So find where your cricothyroid membrane is, palpation. It's basically that little indentation between the thyroid cartilage and your
Or
cricothyroid,
the actual mannequin.
which in this
You
mannequin,
can turn that
I will
guy.
show you. It's right above that slit, but you can kind of see,
Oh, yeah.
actually it's right here.
Oh, there you go. Okay. Yep. Those big.
Yeah, so that's actually where you want to go.
Right.
Well,
right there.
turn the mannequin this way, just so that way the video can
Yeah,
show
that's
it
great.
to the side profile.
Yeah. Oh, there you go. Yeah. Yeah, so you're gonna take your needle and syringe.
Real field.
Yeah. Generally, we do this with gloves on, but, you know,
This case?
this is a real emergency, so we don't have time for that. Yeah, so you're gonna go just straight down. Usually I'm aspirating as I go, so I know
There you go.
the moment that I hit the trachea, you don't want to go all the way through
Oh, yeah.
and pierce the back wall of the trachea. So once you're in, there you're good. Now you hold your needle, disconnect your syringe, grab your guide wire, which is flexible on the end that you're gonna put in. So again, it doesn't penetrate the back wall of the trachea.
Yeah, it's.
You can put it all the way in there until it's gonna bump up against something in the lung, I'm sure. In this case.
Right there.
Yeah, so you're good. So now you take your needle off while keeping your wire in place. Don't accidentally pull your wire out. And then normally I would probably use the scalpel to make a little incision, just, you know, 3 millimeters, maybe wide enough to, allow you to pass the freight. But in this case, the rubber will expand, so you're no problem. So now you're going to need the dilator thing, which is right here. So now you can fit this in there like that, and you can pass them as a unit. Sometimes we'll just dilate first and then put it in, but I think this works best. Doesn't screw tight in there, so you have to hold it. But there you go. Just kind of work your way in. A little bit of I like to twist as I'm going in.
Okay.
Side to side, and particularly in humans.
Tyler.
Yeah.
There, buddy. There we go.
There you go. And then you'll pull out your dilator and wire, and now you're ready to connect an EMBU bag or a ventilator and off to town.
Right on. Thank you.
Good job.
Thank you so much.
My pleasure. You want to try it?
Thanks. I don't know when's the last time I did a bedside tray. Nowadays our trays go to
Really?
40, yeah.
Really?
I think so.
That's opposite of the trend nationwide and globally.
Usually we've
Birth
done
rates are
bedside,
much
yeah.
more common these days, and they're usually done in the United States.
Yeah.
Really no reason to go to those. Where do you work?
I work at Queens. man.
Queens. It's really operator dependent. If it's ENTs that are doing it, what I find in the community is that ENTs they feel more comfortable in the operating room, so they go to the operating room, even if they do a
Yeah,
percutaneous.
I guess it depends on-
Anybody else want to try it? Okay, okay.
If tomorrow, if you didn't get a chance to do this today, tomorrow the mannequin will be there, you
You're
know.
back tomorrow. Okay,
Yeah,
good, good.
we can practice again tomorrow.
I'll be back.
Yeah, and I'll be here too, and I can.
Everyone will be here tomorrow. And for the version, this will be at our conference today, so thank you so much for being here. I really appreciate it. Appreciate all the speakers and everybody. I think it was great. I will see you. Good night.
Oh, yeah. That's actually the hospital. So.
So it makes more sense, right?
Thank you so much.
Yeah, of course. Thank you.
Yeah, I was asking Steve if you would like, and with your permission, we could upload that later, not now, but later upload that video to the website and allow people to just watch it. And I would want you, if Steve does it or you, I would want to put a disclaimer on there, that this is not medical advice. It's for education, so that nobody sues me. But yeah. Yes, I've got it. Yeah.
I'll see you tomorrow.
I can guarantee you
There's
there's
gonna be a prom in here later or something.
No, I wish, but okay. Shane, you're good. I can end the call.
I said good. Oh, they're
Okay.
asking if they, someone's asking if they.
Do we get a PowerPoint presentation? Actually, I should have said it. I want to say it's in the conference page. There's a handout link. I'm gonna write it. Yes, in the conference page, there are things all under handout. Under lecture handout.
Yeah, but the prince was, you know, I was waiting down. And then I bet. I was
I
lucky
just
at that
wanted
time.
to
I had a corporate sponsor. It's just me.
what the heck is happening?
Yeah, your
It-
fingers is not being,
It's can you see it or here
Oh,
we go.
there it
Okay,
is.
okay.
it was off the screen, I think.
Oh
It's
my
not
gosh.
that. It's
Okay,
the,
so I'm gonna
uh,
do this. Okay, so
Oh,
I
there you are.
added to mine. You can I'll give you the flash. I think something happened with okay, thank you. Yeah,
Is that actually it? No,
no, that's something
that's my
else.
talk.
No, that's the vent trainer. That was
But did you get the video?
yeah.
I think that's the PowerPoint of my trach talk.
Oh,
You want
okay,
you
yeah.
want I mean, you can have that too.
But-
You already have that, but you want the video, right?
Yeah, I saw. Oh, maybe I clicked on the wrong thing.
Yeah, I didn't see it. Where is
Oh, okay, the image.
Is it an
That's a
image?
video.
Okay, that's
Yeah,
the
because
video.
that's a movie.
Okay, yeah, that's
Yeah,
the
yeah.
one you
Okay,
want.
so I moved the wrong. I
You
don't
can
know.
have both.
Well,
Or
I
you have
have
the
the other one.
You have
Yeah,
the other one right on in your queue for
Yeah.
tomorrow? Okay.
because you didn't change it or anything, right?
No, I didn't change it at all.
So I'm just gonna. Okay. I'm just gonna say. You can't end this video call. That. What?
Oh,
I think I should. See you soon.